My presentation is one-day visit, but let me thank first Dr. Fred Slede and Dr. Salah Weiss for this kind invitation, and obviously all the Versah people that have been so kind with me. I have a special thank to do, and that is Jorge Campos, that you had a chance to hear now speaking, and all these others, in particular Chuck Schrimmer, Maurice, obviously. It was great to have met these guys, and we shared thoughts and experience on a crowd learning basis. And we did all that on Dental XP. That is an incredible vehicle for learning. So I wish for you the opportunity of learning today, but sharing your knowledge tomorrow with all of us. Just a few words about me. I graduated in medicine, specialist in pathological anatomy. These are my professors. They've been very important researchers on bone. Paolo Bianco wrote this article that I would like you to read if you have any chance to. It's about scaffolds and the way scaffolds can guide the osteoregeneration. I'm also graduated in dentistry, and Professor Martignoni have been a mentor for several generations of dentists, and some of them are very famous, going to lecture all over the world. So I'm honored to have been one of his students. Why one-day visit? Let's say that in medical area, usually multiple surgery is not required. And I think that in implantology, we should start thinking in terms of a single-step procedure. It can become a new field. And at least in Italy, we have two types of population kind. People, very young, moving faster, or old people that they want everything soon. So I thought of this one-day visit concept as a journey that started on 2009, and I would like to share with you the experience of these 8 years on 3D imaging, on 3D digital models, on 3D planning, on 3D printing and milling machine, the new biology healing pattern, we heard Jorge Campos before, the new osteotomy tools, obviously the Densa drill, and many invasive procedures. So let's see this supernumerary here. At the first look in OPT, we would imagine that there is a root resorption, or that patient may experience some pain, but it's not so. If we have some cross, we immediately realize the situation. And that is much more evident when we approach a film. Okay, so you see that we have a 3D rendering. We have in blue the supernumerary. We can zoom on it. We can extract it virtually. Everything is much clearer and much easier when we go and have the clinical approach. But let's see this case here. That's a very interesting case. I will start talking about it at the very beginning of my presentation and at the very end. Now, on 2D, we see a large periapical lesion. This is in acute phase, but we cannot really perceive the limits of the lesion. We have a much more insight when you have cross. You see palatal swelling, large bone defect on palatal area, and a little bit defect on vestibular area. And this is a thin lamina of bone preserved. The visualization on 3D rendering makes it much simpler. You see in vestibular area, this defect, apical. You see the large apical defect and the root relation to the lesion. You see the apical area. And we extracted virtually the tooth so we could have some insight about the morphology of alveolar. So my questions are, how do we manage this area? what are the healing expectations? How do we prevent the bone collapse after the extraction, as Jorge was mentioning earlier on? And less invasive procedures could be of importance for the patient outcome. You just think about it. We'll discuss that at the end of the lecture. So CBCT and Better Dentascan, they have Hounsfield scales. These are called hidden data that you can see here from enamel, D1, 1200, down to hair. So you see the skin and the hair. So when we have a CAM bean, we actually have lots of information, and we can pick those information with appropriate software. And look at this picture here. You have STL and 3D printing models. So if we have a 3D rendering, we can convert that into a file. And you see that we can study very well the roots, the bone configuration, and the alveola. We can then study the morphology of the root. And you see how virtually we can do that very nicely. We can put them back in the alveola, and we can have it in transparency for more insights. And sometimes we need these because it's safe work. Look at this case. It's a real case. In blue, the implant, position it to distal, touching the nerve, alveolar nerve. If we did a planning, we would have placed the implant much more in the middle and far away from the nerve. This patient was experiencing a pain, neuropathic pain. The neuropathic pain is very hard to treat. I hope none of you would have one to treat. So that's what we want to do. We want to have the implant, custom abutment, the crown, in occlusion. We see the gingival tissues and the bone, and we check the nerve and see the connection with the implant. So all this can be done now digitally. And the interesting fact that we have something more to do, and that is to have an interface. And the interface is the surgical stand. Surgical stand allows us to put the implant three-dimensionally in the planning area. And then we have 3D scanners. Now we have intraoral and extraoral. I would like to let you see this new scanner. It's not a picture here, it's a scanner, 3D. It's very interesting because quality of the colors and the image is very, very realistic. The digital scanning needs to be accurate. This is a very important issue. I hear many times saying that few minutes are required. In my experience, it takes about 20 minutes, half an hour. If you want to have very accurate scanning, if you don't have accurate data, all the planning will suffer. And we can get a 3D printing out of this data, so we can have real models. It's very easy to do. And we can also have customs abutment in titanium using a pre-milled abutment and a milling machine. Or T-base connection. So we have a T-base with the implant connection and some zirconia that will be milled in a custom fashion with the provisional or definitive crowns. Another thing I want to talk about is the connection. Look at this. When we apply diagonal force, there is a problem in the connection that we do not experience when we have a switching platform and a conomorph connection. So my idea is that I want to have stable connections if I want to do a one-day visit. And PRF, we all know PRF. Just a little tip I want to share with you. PRF should not contain any red part, possibly, as the red blood cell may interfere with the healing process. So we only want yellow parts. And obviously, they are very nice for closure, primary closure and soft healing maturation. We also have some new instruments that we may use during our surgical procedures that will inform us if we can place an immediate load on the implant. So generally, it is recommended not to be lower than 40 Newton. And you also have a torque wrench in case you want to do it manually. We know from Salah yesterday about this curve. Just want to make two observations. This is not a number, it's a percentage. This is very important. The more the torque is high, the less the curve will be ripped, so it will be more towards left. And below here, same thing. This is big, bone implant contact. The more big we have, the more this curve will go on the left. So in the long run, if we have a good torque and a good big, we may try a one-day visit, and at any rate, this value will be much higher and we reach it much sooner. So let's see now planning. Place the implant. I want to be at least 2 millimeters between the two roots. And there's an angle, so I want to see and pre-visualize how to correct that angle with an abutment. And then I want to place it in the bone and check how it fits, made some crowns, and maintain the first bone, trabecula, and measure from that trabecula to the contact point. It's about 5. So we know from Turner that we could maintain the papilla. So all these informations that I will call data are very important, because data will enable us to go to the surgical phase with more comfort. These are the procedures on guided surgery. Universal guide, you have a reduction, and safe guide, no reduction. Personally, I prefer the universal guide. Universal guide because it's very versatile, and you can use that about 95% of the time. There's few times you cannot use it. Safe guides, any brand, will not be used more than 40–50% of the time. So let's see this initial case. We want to place an implant here. Surgical stand. I try it first always. You may want to try it to see the fit and to see that it's perfect. If it's not, just throw it away and go back to the planning. So I put the implant and I put a scan transfer immediately. And this was done with CEREC. So you see the real prosthetic items, the abutment, the crown, and virtual elements. And this is immediate. This is immediately after, not really in the same time, because this is 2011. At that time, zirconia required about 8 hours for sinterization. So I had to wait. I called the patient in the morning and I put everything in the afternoon. This is the X-ray control. At that time, we wanted to make sure that the implant was accurate. So you see in red the virtual implant. Let me get back. So you see in red the virtual implant and in yellow the real implant. Mauricio, can I go? Okay. That's it. Okay. Okay. So what we did here, we superimposed the two. See the real implant in yellow. We removed that. First of all, we superimposed that, and you see it's just nearly perfect. Superimposition between the two. Then we removed the implant, and there was a space left. And we put back the virtual implant, and you can hardly tell the difference. Look at this. Before, after, before. See, you can't tell the difference. This means that there is a lot of accuracy in the surgical stand. See again? And this is a 4 years control. So we have a one-day visit, one shot, and patient seems very stable at 4 years. That's another case, one-day visit. In this case, we did a pre-production. So the first one was a post-production. We do a pre-production now. Unfortunately, I didn't met Jorge, so it's a full extraction, immediate abutment. You see the result at 10 days, very nice. The X-ray control, and this is a 4-year control. System works, but we should be, in this case, very careful in the selection of the patient and of the case. That's another case, very interesting, because I want to show you what we can do now with the roots. You see these roots is very thin here, and we got the implant. When we see the green of the implant, that means that most of the implant is bone contacting bone. If we don't see that, that means that we are on an empty space. So we just did the extraction, full extraction. The alveolar is elliptic. So at time 0, what we want to do, we want to occupy that space in an elliptic shape. And this is the immediate result. The X-ray control, everything seems to work. But if you look carefully, at 20 days, you already have some loss in the volume here, okay? So I didn't quite like that. So at this point, I have a sliding door. Either go to Bologna, and there's this very famous periodontist, and do some soft tissue surgery, or meet Jorge. Where is he? So I met Jorge. So as Jorge showed you this morning about the Hürstler experience, I want to show you the Araujo experience, which has been very important and famous, and carefully check the two and the difference between the two. Araujo said two things. If you extract the tooth and put the implant will not prevent bone resorption. And secondly, there is always a bundle bone resorption, much more pronounced on the vestibular area. Hürstler, he realized, he put the lamina of dentin there, and I want to show you some little details. The bone peak here is slightly higher than the bone peak on palatal area. That means that we had some resorption here, little, but we do. Now, this matters clinically, because when we want to position an abutment at day 1, we have to know that we may go through some palatal resorption within a certain amount of time. So often when we see these histologies, we're not aware that we can find these in our clinical experience. But look at this. We have the bandal bone preserved. We have a large bone palatal preserved. We know that. We know that the bone palatally is less prone to resorb. And we have the socket shield. So you see that clinically, the Arujo experience works. But let's see now the Baumer experience that is very close with the data that Jorge showed us this morning. I want to make some new thoughts with you. Now, when we focus on these slides, we always focus here and we look for bone. But I would like you to have a different thought. We have bone here, we have dentin here, we have bone here, and the implant here. These four have ligament here in between and bone here in between. So in fact, bone and dentin are a unity because the bone is gluing dentin and implant. So this is a real unity, functional unity. And this is, in my opinion, very important for the long-term maintenance of the bone wall. So, can we experience that clinically? Look at this patient. I was attempting a socket shield. I was not very good. The root breaks, but this is a vital root. In my opinion, the primary quality of the root may be of importance if we want bone regeneration in the area. So look what happens at time 0. We have an empty space, and then when the time goes, we have this space filled with something that is a calcified tissue. We cannot say it's bone, but certainly it's something calcified that has a very tight contact with the dentin. And this patient, see, I used a healing cap and I did a scan transfer. And this is the abutment. And let me go back. And I would like to show you this area. Very natural, as Jorge was saying before. You don't need to do much more than that. There are some cases very simple. This is one of the cases. This patient has lateral that is failing, removed it, placed an implant, provisional. That's the definitive. This is an easy case. We had large amount of bone, so it's very simple to do. In this case, what I would like to show you is the socket shield and the morphology that I try and obtain. In fact, that the use of Densidrill may autograft the bone wall, the lingual one. And in my opinion, that could be improving the outcome of healing phase. We have now some stoppers that will be shortly available. They may improve our predictability in depth control. This is the implant. When we remove the socket shield, we always try and remove the apex whenever possible. I feel more comfortable in that way. This is an immediate provisional, but I want to show you this. Look at the soft tissue and the volume here, and look at the soft tissue and the volume in this area where the patient had implants from some years before. There is total destroying of the architecture here, and we maintain everything, just maintaining the socket shield. The Versah is doing a C-shape guided surgery for the Densidrill, And this is a preliminary study that we are trying to do. They seem very accurate, but we are in the phase of experiencing it clinically about, about in a month's time. So maybe if you want some information about it, you can gather on Facebook and friends who likes Versah. PET can be performed on molar area. In this case, I use a safe guide to make sure I had the right direction for the connection. These are the items that I produced. So I put the implant in, I put some PRF, and the immediate provisional crown. And these are the healing phase. Look at this area. The X-ray control, no bone loss, and that area is nicely healed at 1 year. One Baumer observation that I have too as data is that the final crown is always smaller than the initial one because it's some kind of tissue bending. And when we plan our abutment, we always want to make it a little bit smaller. So the molar will be always smaller. That's another socket shield. You have some clinical aspect. What I'm trying to do, you see some gutta percha here, I want to remove it. I'll try to be within the tooth always and clean the inner part and thin the labial part and remove the other. What's interesting here is that I prepare the area and I use the denser drill and I could do a subcrestal elevation of the sinus. Why did I do that? I'll show you. This is the implant, the immediate abutment. You see 7 days result, and this is a control at 7 days and at 40 days. So this is all the study that we do, because when we go there and place the abutment, we have studied that before into a planning. So we just carefully check the marginal gingiva. And what you can see here is very interesting. This is implantocentric. We have the implant in the middle and the bone that will turn all around. So we have a lot of insights about the quality of the bone around the implant. And you see here what I said before. In this case, you see very little red and a lot of blue. That means that the bone contact is not so much. This is why I wanted to have a contact on the bone lining into the sinus. So the very initial apical implant area had to be connected with a solid, stable bone. See? You have palatal and vestibular, no bone. Again, we have margin definitions. What's interesting here is that when we plan the abutment, we have this pre-milled here, virtual, and we know before if the design we had could be released by the milling machine or not. The socket shield design can be performed on lower molar area. We don't have really a consensus on the design, so every one of us decides according to his own experience. So this is my choice. What I would like to show you in this interesting case is this area here, you see? Okay, this is my very first case, and I lost the distal part of the root. And you can tell that out of reading the morphology of the volumes on vestibular area. We can use denser drill again for immediate implant. And where's Martin? This is the slurry bone. I like very much this kind of terminology, because when you use Versah on some quality of bone, you kind of have a slurry bone. So this is the slurry bone of Martin. We place the implant and we put some PRF. And I put a provisional. What's interesting here that the digital can allow us to do many things, and we can be very creative. So what we did here, we have same configuration in the inner part and different occlusal configuration. So we just removed the provisional and put the definitive, and will fit perfectly because we designed it in the same way. Okay. If we want to be in the septum, we can plan it, and we can have a surgical stent that really does that, as you can see here. So before I remove the roots, I want to define my septum area. So out of defining that, and the use of Versah drill here is extremely important, because it enables us to maintain the volumes around and the beak, allowing the possibility of placing an immediate abutment and crown provisional. So you see some studies here, Martin. I tried and put some images here for you. They kind of difficult to read, but the interesting thing is that we need to have some reference point, and we measure. This is the abutment that you can see here. Okay, the abutment profile is anatomical. So we want to follow the anatomy, and we'll incorporate some biological information. So the idea of socket shield is very important, because it allows us a predictable result in terms of labial soft and hard tissue stability. And this is the abutment and crown. This is made in zirconia. We did an immediate abutment in zirconia, crown in zirconia. You see the old study. We can do a virtual socket shield and see the relation between the socket shield and the implant and the abutment and the crown. So this is the socket shield performed. We try and be very delicate and on soft tissue all around, not to stress them too much. We use a guide. This is the immediate abutment, X-ray control, and the crown immediately placed. Now look at the result. This is at 10 months. Very natural. I removed the crown because I want to see the tissue here all around. Can you say that this is an abutment and below it there is an implant? Seems very natural. And as Jorge said, we didn't have much to do, just to remove half a root. So let's go to the initial case. Main questions: how do we manage the area? Do you have an idea how do we manage this area now? How to prevent vestibular bone collapse? This is always, Jorge told us this morning, there's always bone collapse. Can we do less invasive procedures? If this was your mother, how many procedures would you do? I'll tell you what I did. This is the initial case, and I did a partial extraction therapy. Sucker shield, look the progression of the radiological healing with the reduction of radio transparency in time. And look at the soft tissue healing. We just performed a sucker shield. So 6 months later, with a needle, I wanted to test if this area there was bone formed, because this patient had you remember, very large palatal bone loss. But the needle couldn't go in, so I knew that was bone there. And we did this flapless. And I've used the Densidrill on flapless situations, no problem. It doesn't affect soft tissue at all. So I'm perfectly using them. And I use them here now for 2 reasons: to be mini-invasive and to do a little crestal, subcrestal elevation of the sinus. Look at the virtual and actual plan, how they look alike. And this is the final result. Well, let me go back here. Okay, now I want to show you this. Okay, this is the implant just placed here, and you see some radiolucency here, but that disappeared after 12 months. So complete healing there. And this is the final picture. So maintenance of the papilla, natural look. I don't have time to discuss about this case, but it's very interesting because we always talk about biology. We should talk about biology and biomechanics too. So my conclusion is that data will probably lead our clinical experience in future years. And data are usable the day after. If any of you is doing planning, could gather informations today and put it on practice tomorrow, because a data, put it on the planning, becomes a real value. And planning together with new technology like Sucker Shield and Densidrill will simplify the procedures, as Jorgen mentioned, and a larger number of dentists will apply to implants. Patients will require simple, predictable outcome in a one-day visit basis. We can't expect to do multiple surgery if we have tools that enables us to be predictable and simpler. So data is the alphabet of digital planning. Some data may not be sufficient to have meaningful information. Some data are key data, providing an immediate and useful clinical information. I'm sure that most of you recognize this painting. But full data are always required for a complete picture analysis. So all of us is involved in finding new data to have a complete, clear picture. So I'll show you this little film because I think one of the main key data is osseodensification. We can have a bone expanding, autografting, crestal sinus elevation, maintenance of the bone thickness, beak improving, torque improving, and no micro movement and initial stability. If we don't have all these, digital planning and one-day visit cannot be performed. One of the things I didn't talk about, but was intrinsic in the concept of one-day visit, is that the abutment concept is 1A, 1T proposed by Dr. Salama. We don't want to remove it. That's why I'm looking forward for one stable connection. And not removing the abutment, in my opinion, is also a key. So let me thank my son, Stefano. Stefano did all the work here. He did the artwork, producing all the digital films and digital data. He's working with me every day, 6 years now, and he's doing all the planning. So I wish to thank Stefano, and thank you all for your kind attention.